find our way back to our seats, give us a 30 seconds or so, and then we'll start our second and last panel of the day. You guys are good. Again, my name is Sam Howard, and I am happy to be introducing this panel because health professional workforce is something that I've been interested in from a research perspective for a number of years and currently involved in standing up the NewMexico Center for Health Workforce Analysis over at the Health Sciences Center, which I am not even optimistic. I know for certain we'll be able to produce very, very, very nuanced reports about the landscape of health professionals in the state. And I won't talk a lot about that. Hopefully next time we do a summit with the workforce as a topic, we'll be able to present some of the findings from that center. It's in its infancy, but huge potential. So I'm going to introduce Congresswoman Johnson, who is joining us today to introduce the panel. And I'll turn it over to you right now.
Good morning. In the book, I'm Bob Lee, but in real life, I'm Bernice Johnson from Dallas, Texas. And my voice might go and come just because I have damage to my right vocal cords, but if you don't hear me, let me know, because I'm not always sure about the volume myself. But it is a pleasure to be here today. I was invited Thursday afternoon, and I was at a conference. And I couldn't really talk when Barbara called me, so I referred her to call my office and talk to my scheduler so I could really tell what she was calling about. Well, the next thing I knew, I was replacing her on this program this morning. And so I'm delighted to be here because my colleagues that are here are very close. I have one colleague that's a classmate, and when we say classmate, that means we were elected at the same time, and that's Congresswoman Romero, the class of '92 for Congress. And so I'd like to thank her for leading the charge on this Tri-Caucus Health Forum. When I was chair of the Congressional Black Caucus, I organized the Tri-Caucus. And so that was a guilt trip that was put on me as well. This is your thing, so you need to go. So, I'm here. It's really no secret that the United States is going through a tremendous and drastic change in demographics, and will continue to do that for the next decades. And because of this, it is more important than ever that health professionals improve and increase in numbers, because we do have to relate to patients. I did get here early enough to hear much of the panel before on the psychology or psychiatric aspects of mental health. And that will be a key area, just as attempting to make sure we have diversity and numbers in the caring end of the professions too. The most effective way to have a culturally competent health workforce is to have a diverse health workforce that more closely resemble the population. And currently, we are in stress of trying to get there. But I hope that you, the audience, will be the torchbearers to make sure that we can achieve that. Because it's everyone's issue. It's everyone's responsibility, and most especially professionals and those who are studying in the area. Because there's nothing like a role model that can influence others. And so not only do we need more in the caring professions, we need more minorities. Because we need to address the population. When I first ran for office, and it was a long time ago, I became the first nurse in the Texas House of Representatives, then the first nurse in the Texas Senate, and then the first professional nurse in the U.S. Congress. encourage a lot of specialty. And it does help. I had been the chief psychiatric nurse at the Veterans Administration Hospital in Dallas. And it really does help to have those skills in the background. And I find that nursing has such a holistic approach in its curriculum that it can address almost every other profession in a sense. It kind of gets you ready for the kind of unexpected, the immediate changes, like I immediately changed my schedule to come here today. But you're always ready for the unexpected. And I think that that's a good trait to have. You're also not hesitant to make strong decisions quickly, which is also a good trait to have no matter what profession you choose. But at this time, allow me to introduce our most skilled and distinguished panel members. Dr. Gabriel Sanchez is the Interim Executive Director for the Robert Wood Johnson Center for Health Policy here at the university, and also a professor of political science. Kat Badauza is the Associate Director at the Center for Health Professions at the University of California in San Francisco. We all would like to live in San Francisco most of the time because of the weather. And Patricia Montoya, who I'm reacquainting myself with, who worked with the Clinton administration. She is now the director for the NewMexico Coalition for Healthcare Quality, and she's a registered nurse. Valerie Leggott is the Vice Chancellor for Diversity at the University of New Mexico Health Science Center here in Albuquerque. And I think you will enjoy all of them because they're all very well prepared for this panel.
Good morning. Before I get into my formal talk, I'll put on my conference or summit organizer hat really quickly and just take a second to recognize Kevin McDonald in the back doing our live streaming of the event from KNME, our PBS affiliate. If you're not aware, we've been live streaming the event since yesterday at the beginning, and we had well over 100 folks yesterday tune in to check us out on the live stream. So I'll just give a quick note that we're working on being able to we have that recorded and be able to put that on our website for the rest of you that might have colleagues that weren't able to attend and be able to see the content. So as you can see, my formal discussion today I think will be an interesting way to kick off this panel, because in the context of workforce, what I'm really going to be talking about is the initiatives that the Robert Wood Johnson Foundation is really engaged with, that is focused on workforce, but not in the way that I think a lot of us think about workforce, which is really health professionals, but more so policy expertise, with a specific emphasis on diversifying the policy experts that can really tackle some of the challenges we have in terms of public policy. So, most discussions of workforce, and this happened within the context of our planning group, we immediately started thinking about doctors, nurses, other healthcare professionals that obviously we're in a critical juncture, as the ACA is obviously increasing demand for those services. Unfortunately, right, the supply is staying flat. So we're all acutely aware of the critical nature of how much the workforce needs to be increased, but also with a specific emphasis on diversity within the workforce, as already been noted. But one of the things we really wanted to touch on is there's also a critical need that is not really talked about as much, and that's a pool of talented scholars, right, that can not only produce research that can be useful for Congress and other legislative bodies, but also can sit at the policymaking table, whether they go on to Congress, state legislatures, whatever it might be. We don't focus as much attention on that element of workforce. And that's going to be the little context that I provide and really talk specifically about Robert Wood Johnson's efforts to do something about that. So you saw this slide yesterday. This is Latino Decisions data that we basically asked the Latino community, do you believe Latinos' interests are being included in the context of healthcare reform? You saw, as my colleague Matt Barreto noted, unfortunately, about half the Latino population says no, not much. In fact, way too many folks are saying not at all, right? That they don't perceive that their voice really matters in the context of healthcare policy. One thing my colleague didn't notice, over the year leading up to the election with Infomedia, we did one survey every single month on a different public policy issue: immigration, education, economic policy. And in every single survey, we asked the same question. And I could pop in immigration policy, I could throw in there whatever other public policy we were talking about, it was almost the exact same pie chart. In every single context, the majority of Latinos are saying our voices aren't being considered. We don't feel that our considerations are actually being implemented in the context of public policy. So that's the backdrop in which I'm going to use in the sense of arguing or trying to provide with data and some of the programs that we're doing, an argument that there needs to be more emphasis on trying to engage diversity in this area to hopefully trickle down to the community. One of the reasons that I know this is when I cross-tab this data with whether or not you're represented by a descriptive member of Congress, right? Somebody that looks like you in the context of your elected official, these numbers change significantly. Long story short, when you're represented by somebody who looks like you, racially and ethnically speaking, you're more likely to think that your interests are being considered. Why? Because they most likely are being considered at a more acute level than if you're represented by somebody who doesn't understand the context of where you're coming from. So within this broader standpoint, I think political science can be very useful to this discussion because we study descriptive representation, this notion of whether it matters if you're represented by somebody that looks like you physically, they come from the same socioeconomic background, the same gender, and so forth. So political science has really done a lot to focus specifically on Congress. This is an area of research myself. Several of our PhD students in political science here are focusing on congressional representation, and we know quite a lot about that. Unfortunately, even with the huge diversity that came in with the most recent 113th Congress, if you're not aware of this, that's the most diverse class in the history of the US Congress. Right? So a lot to be happy about, but unfortunately, even with that influx of diversity, Congress essentially is still white and is essentially still male. Approximately 68% of Congress these days is white males, even with that influx of diversity. That's well studied. There's literally libraries full of books of scholars that have been studying descriptive representation within the congressional context. We know quite a bit about why that matters. It leads to different public policy outcomes. And also, less talked about is it really increases efficacy and trust in government among the population. So seeing diversity within our legislative bodies leads the public to say, I'm more likely to believe that the public policy outcomes match what I want. I feel like our voices are being heard. And that filters down into everything, including increasing the population's likelihood of voting. So we know quite a bit about that. What's not as well understood is, well, what about representation in other realms of the policymaking process? What about bureaucracies? What about think tanks? Or what about all the other pieces of the public policymaking process? Political science is beginning to engage in that discussion, specifically in the context of diversity across those other bodies, but we know less about that. A couple of things to point out is whether we look at state legislatures and other bodies, bottom line is, despite the fact that Congress tends to be underrepresented in terms of racial and ethnic diversity, when you look at all those other pieces of the policymaking process, particularly high-level staffers, think tanks, people at universities producing research, unfortunately, the representation is even worse. So that's one thing that I really want to focus on in today's talk, the time that I have with you today is, well, if we're not studying that, the numbers aren't good, what can we do to actually improve descriptive representation as it relates to other aspects of the public policy making process? And that's really what I'll focus on, largely because we know that representation matters tremendously to outcomes. There's been tons of research that shows, for example, when you have cities represented by an African-American mayor, all other elements of the policy-making process underneath his or her leadership changes in a positive way. You have more descriptive representation at all levels, right? And not only does that matter in terms of improving efficacy and engaging the population in the political system, but the policy outcomes change. They tend to be more reflective and in the substantive interests of the populations of the communities that they serve. So I think that's the important backdrop that I want to kind of contextualize what I have to say today. So what is RWJF doing, the Robert Wood Johnson Foundation? Well, if you're not aware, they have a huge human capital program that essentially addresses this specific issue. They essentially say, look, we've got a lot of programs aimed at postdocs, people who are already finished with their doctoral programs, and in trying to improve really healthcare professionals in terms of diversity and their training and backgrounds to be more culturally competent. But a relatively new piece to the large human capital program is focused more on doctoral students, trying to engage folks early in their stages of their academic careers to think about health policy, move into those realms instead of doing something else with their career to hopefully improve the overall policy discussions that we have. In the context of our center, one of the things that's emphasized here, you see some of the guiding principles that drive RWJ's human capital program, leadership development that I'll touch on in terms of our training of our students, developing a skilled workforce, obviously in the context of this panel, research and analysis. I'll talk a little bit about in context of research, it's not just about engaging in high quality research, but we just heard the Congresswoman say it's important for that research to get in the hands of the media, get in the hands of Congress and other policymakers. That takes specific training, right? You're not usually guiding a PhD program on how to actually produce research that can end up in the hands of policymakers. That's something that RWJ is focusing attention on. How do you actually do that? What are the best practices and so forth? But you see the one that I highlight is diversity. Is front and center in Robert Wood Johnson's efforts. I won't read this to you, but essentially it says that the bottom line is, if we want to change health policy outcomes, one of the things that has to happen is changing the makeup of who those decision makers actually are. If Dr. Lumpkin, Vice President at RWJF, were here, he's the individual that basically came up with these particular centers and the ideas behind them. When I asked him, how did this come to development? His long story short of it is, he says, look, he's an African-American man. He says, when I go into high-level policy discussions, I look around the room and I'm the only person of color, period, ever, in those discussions. And he says, I always felt that that's why we have the same conversations that have been happening for decades. That's why we have the same policy outcomes that we've been seeing for decades. So his perspective was, how do we as a foundation change that dynamic? How do we improve the overall makeup of these decision makers? And his perspective was, let's think about this from the ground up. What programs can we put in place that will improve the overall pool of individuals that could go into these fields? And what training mechanisms can we put in place to make sure once they're graduated and moving into their careers, they actually have the skill set and the foundation to be able to engage in policy-making decisions so that, bottom line, outcomes change. So we're part of a larger team. UNM's RWJF Center is just one of a few that is really focusing on this effort and is being well funded by Robert Wood Johnson to try to do just that, diversify the workforce, specifically in the context of public policy. So one of our sister programs is a research center very similar to ours here at UNM. That's at Meharry Medical College, a historically black college and university and a medical school campus, but also collaborates with Vanderbilt University there in Tennessee. And so essentially what they do is the research center itself sits at Meharry Medical College, but all the PhD training happens at Vanderbilt. And so they're working collaboratively with each other to try to figure out how do we utilize the resources in the context of the RWJF Center to try to improve the training specific to health policy, while folks are also being trained as political scientists, economists, sociologists, and so forth. So it's somewhat of a collaborative effort to make sure that they have the skills necessary to be good policy experts, but at the same time, they have the skill set also in public policy. That's a challenge that I'll talk a little bit about. That doesn't come naturally, unfortunately. What I want to highlight in the context of our collaboration with that particular center, which has really significantly increased over the last few years, one of the things that we're doing is really cross-pollination, trying to send more of our PhD students here at the University of New Mexico their way and bringing on interns over the summer here at the University of New Mexico. So this particular summer, we hosted 2 of their doctoral students at the University of New Mexico, and the thing that they were most interested in learning more about is Native American health. They both, in terms of their interview, said that's the main thing that they wanted to achieve in terms of their summer here at the University of New Mexico, because they're not exposed to that, even the region that they're located. Those individuals left with a much greater understanding of community-based participatory research, one of the strong points of UNM's medical school, and they were fascinated by the things that they learned and said, look, we can transplant what we're learning here at the University of New Mexico with our curriculum back at Meharry and really emphasize some of the elements they learned in terms of cultural competency when they're really focused on their own research that's more specific to the African American community. The RWJF Center here at the University of New Mexico is strategically focused on Latino and Native American PhD students. Meharry Medical School, obviously, because of the regional focus and their history, focuses more exclusively on the African American population, and their research really focuses on trying to improve the same capacities for the African American community. So I want to highlight them. You have the opportunity, I believe there's some materials out there. If you want to learn more about this program, I would strongly encourage folks to think a little bit about, if you have access to undergraduate students, folks thinking about coming back to graduate school, to think about one of these programs as a place to maybe end up. We also were very fortunate to work closely with the Nursing Collaborative here in the College of Nursing. It's very similar to ours, funded by Robert Wood Johnson, but has a very specific emphasis on diversifying the nursing workforce in the context of PhDs and scholars. So we work very closely. You see, unfortunately, Dr. Sally Cohen, the director of that center, was on the East Coast. She was not able to be here today. One of the pictures, Dr. Barbara Dameron, who I know was here yesterday, I don't know if she's here today, she was able to really emphasize some of the collaborations along with Dr. Cohen, because because we really feel that we need some of those folks that, as you noted in terms of the nursing profession, bring that on-the-ground emphasis to our conversations about social science. Right? And that really is very rare across the country. It's really, I think, a beacon of hope for what we can do collaboratively in the future on a larger scale. So what does the RWJF Center provide? One of the things that I want to emphasize is I think if you think about what we're doing and scale it up, especially when we look at some of our success rates, I think this is a model that can be implemented across the country as a mechanism of changing the way we train doctoral students, and more importantly, in my opinion, training the way we recruit and enroll across our graduate programs. So a couple of things that I'll highlight is, we have a fellowship program that's across the social sciences here at the University of New Mexico, economics, political science, sociology, but also psychology and anthropology. So we're an extremely interdisciplinary unit on campus, and we really focus on an interdisciplinary level of training. We provide a comprehensive fellowship experience, so it's not just the money. Obviously, there's a pretty generous fellowship package that comes along with that to try to recruit students and sustain them through 5 years of their doctoral education. But I think more important in terms of our success rates is the fact that we have a very comprehensive approach in how we prepare and train our students. We have everything from in-house statistical support, which is a major issue, particularly for students of color going through PhD programs, in-house writing support, so they get to know these folks on a personal level, not only their research interests, but their personal lives. And that, I think, really improves the mechanism of somebody being able to go and seek out help. I know myself going through graduate program, the main struggle I had was statistics and not really being comfortable with asking for help. Never been used to having to do that before in my life. And as you're struggling through statistics, your self-confidence is already at its lowest point, and just asking for help is a tremendous obstacle. So some of those comprehensive pieces that we put in place to make sure that our fellows have everything that they really need to succeed is, I think, a model that other places should be looking at. It's one thing to just admit more minority students into PhD programs. It's another thing to really focus emphasis on making sure that they graduate. And I think that's one of the strong suits of what we're doing at RWJ. We have a couple of other programs as well. You see postdoc fellowships and visiting graduate fellowships, mainly as a mechanism to bring more folks in collaboration with us to expose our fellows to a wider range of scholars. One of the things that's already been noted is it's one thing to produce high quality research. It's another thing to do research that's policy relevant. And so when we think about our training model, we emphasize a lot of other things that the PhD programs, not only at UNM but across the country, just really do not do. Some of those have already been noted as media training. How do you actually try to get your research in the hands of the media so that it's hopefully useful not only to the general population but also policymakers? That's a skill set that we actually provide. We've done workshops on this, full-fledged 2-day workshops and seminars trying to make sure that our fellows know how to use all the modern technology but also how to do interviews. And so you kind of see across the board policy internships, trying to get more of our folks. You heard yesterday that one of our PhD students is actually closing out a fellowship that she has in Washington, D.C., working with our esteemed member of Congress. So those are the things that we want to do more of, get more of our folks engaged in the policymaking process so they end the day not only as extremely qualified experts, topical experts, but also have a background to be able to engage in public policy. One thing that I'll note at the bottom, I know I'm running out of time, and I just want to check, I think we had 17 minutes, so I might go a little bit longer than the couple minutes I have left, if that's okay. I want to get you some of the data. But one of the things that I really want to emphasize is this is extremely unique in terms of an approach with PhD programs. Any of us who have gone through PhD programs will know media training, applied policy, not only was not provided, it was often highly discouraged. And unfortunately, all the way to this point, we still struggle with those same issues. So not unique to UNM, when we're talking about sending our folks to DC, or we're talking about doing local policy externships, that's not exactly met with open arms by the academic disciplines, right? They say, look, we want to produce PhDs that go on to be academicians. You're potentially steering them in a direction that doesn't help with our accreditation, doesn't help with our rankings. So I want to note that what we're trying to do here at UNM does not come without challenges. Both in terms of trying to change the curriculums across the social science programs, but also recruiting students, because the pool of individuals who want to go into PhD programs are also thinking a lot about other workforce issues, particularly going to medical school. So that's something that we can talk a little bit about in Q&A. I want to show you a little bit of our distribution in terms of racial and ethnic dynamic of our fellows. Again, we are extremely explicit in how we recruit and how we actually select our fellows. Because we're privately funded, we actually can put in our scoring sheet basically added points if you come from diverse backgrounds. Now with Dr. Nancy Lopez at the helm in terms of our recruitment here in sociology, she's actually taking the work that I did a step further. And she's saying, let's actually track whether or not folks are first-generation students, what is their family's economic background, all those other pieces of the puzzle to make sure when we talk about diversity, it's not as simple as this pie chart, just looking at racial and ethnic background, but across the board. And those are things that we can actually implement. And you see in terms of our numbers, obviously we're doing a very good job with the Hispanic representation. One thing that is, as long as I'm on the saddle in terms of leadership at the RWJF Center, we will get better in the context of recruiting and retaining our American Indian students at a much higher rate. One thing in the point of context, when you look at these numbers, keep in mind that nationally, if you take a look at the census data, if you look at how many Latinos in the country have PhDs, it's 0.5%. How many Native Americans across the country have PhDs? It's about 0.1%, right? So take that into context when you look at some of the numbers that the center here at UNM is producing. Completely interdisciplinary, you see here we work across several different disciplines, sociology, psychology, poli-sci, and so forth, and we really emphasize, not only in terms of who we recruit, but how we train our students, that it's not good enough these days to just be a strong political scientist. You need to be able to work in interdisciplinary teams, including nursing, to be able to actually go out and tackle public policy from a comprehensive way, not just in your silo discipline. In terms of success rates, you see, in terms of national numbers, we're by far leading the pack by a significant margin in terms of our ability not only to recruit these students, but make sure they have what they need to be able to be retained. You stare at the numbers here, what I really want to emphasize is what we had to celebrate over the past year alone. We have 5 new alumni. We graduated 5 PhDs, all who were Latino or Native American last year alone. And already into this academic semester, I've already had 2 successful PhD defenses, both Latino students. So when you think about what we're doing, if you think about scaling that up in size, we can really have a huge lasting impact, not only on improving the minority percentage of PhDs across the country, but making sure those folks are specifically trained to be able to tackle some of these workforce issues in the context of public policy. So I want to close by saying any of you who have access to students, please send them my way. You have a bunch of support materials, including our call for the fellowship. Interact with some of our PhD students that you'll be able to see today. And hopefully this has been informative, again, in the context of workforce, specifically trying to diversify not only health professionals, but public policy experts as well. Thank you.
Hi, good morning. It's good to be here. I am Dower. I'm Associate Director at the Center for Health Professions at the University of California, San Francisco. You can see my bio in the brochure, and you can see my long CV. I've got all the credentials, I think, that allow me to talk today, but I want to take a minute to tell you the things that you don't see in my CV and my bio, because I've heard a lot over the past, I got in midday yesterday, so just a day and a half, about relationships and telling stories. And I think it's important because we are here together for some reason. It's not because this is the best place in the world to be on a Saturday morning. It is lovely, but it's because of the people and the work that we're all doing together. I was raised female, white, in mid-60s, San Francisco, working class, dysfunctional Irish Catholic family. And the broader extended family included Latinos, African Americans, and all of those characteristics both opened doors and closed doors for me. I had experiences that made me see that there was discrimination, that there were problems, and I also had some perspective afforded to me. So all of those things helped drive. I had the opportunity and the misfortune to have, I needed surgeries, a couple surgeries when I was a small child, and so I was exposed to the healthcare system, and I'm forever grateful to the good, competent work that they did, and also really disturbed by the physical abuse and the emotional trauma that I went through at the hands of some of the professionals. I had the opportunity to go to school, and when I saw discrimination, particularly against girls, I first noticed it in 6th grade when I found out that the girls were being sent to choir and the boys were being sent to applied math classes. And this was done for years, until I was kicked off the choir for lack of singing ability. I was the first girl to ever be kicked off the choir. But I went into the classroom and I was shocked that the boys were getting applied math skills. And I complained to my grandmother about that, and she said, don't complain because things are so much better than they were when I was a girl. And so I remember those things, and those things are important. So I did have the opportunity to go to school, to get a degree, first person in my family to get a college degree, first person to get a professional degree. I became a lawyer. Don't hold it against me. And I know I'm very fortunate to work with a number of doctors and nurses and health professionals, and I'm always humbled because health professionals, particularly nurses, are the most trusted profession in America. And while I'm proud of my profession, I know that we're way down there, just about the used car salespeople. So working with health professionals keep me honest, and I appreciate that. And I'm also, I'm fortunate that I've got children now who get it, they understand what I do, and we try to share as a family what everybody's working on together. And I love what my daughter wrote in her 5th grade class about describing her mom's work. She said, my mother Kathleen works at UCSF. She studies different doctors' offices around the U.S. and tries to improve their work and health laws through reports, oral as well as written. Oral reports. Okay, so I'm here to talk about health disparities. How can the healthcare workforce close the gap? Is the microphone okay? I'm getting a lot of feedback. You're okay? Okay. So this is a huge topic, but we're going to try to, I can talk quickly, so hang on. Forward. That was not forward, huh? Okay, preventable disparities. I just did a piece for Health Affairs, so I'm familiar with all the literature right now. The main categories that I would use to categorize preventable disparities, these are the ones that we can prevent, fall into 3 main categories: modifiable behaviors, the social, cultural, and physical environment, and healthcare. Those are 3 separate categories. We spend a lot of time on this bottom area, healthcare, the systems and the providers, so a lot of attention and money is spent, even though it's the top 2 categories that really have the highest impact on death rates. So I'm going to be framing my comments today in terms of what can and should be the role of healthcare professionals in addressing those disparities in the areas that we can address. So the first area is, well, we can do what we've been doing, but do it better. And this includes learning how to counsel patients better on modifiable behaviors. These are the things that affect the death rates and affect the preventable disparities and the inequities. And there's a lot of inability and lack of capacity in the current healthcare workforce to really know how to counsel patients on diet, on exercise, on tobacco use, on substance abuse. People don't say that, but it's absolutely true that we have a lot of healthcare professionals, primary care included, that don't know how to counsel people on these things. So that's a huge area that we need to work on. And it is being done, but there's a long road ahead of us. Be culturally sensitive. It's 3 words that are so easy to say and so hard to do. We have a number of people around the country now working on programs, on laws. We now have laws in some states that require CE for doctors to include cultural competence, and yet we still see this lack of connection, lack of relationship, lack of being able to speak to the patient or the client. So being able to understand cultural sensitivity is really important. I'm actually really concerned with the work that came out this year by Justin Dimmock and his colleagues, finding that in areas where, in America, that blacks live more closely, they're closer to the high-quality hospitals, but the blacks are getting their surgeries at the lower-quality hospitals. So the blacks are living closer than the whites to the high-quality hospitals, but they're getting their surgeries at the lower-quality hospitals. This is disturbing because it means that the referral patterns are playing a role in that. It's not just that individual people are choosing their hospitals, they are working with their doctors, with their surgeons in getting those referrals. So there's something going on there that is connected to cultural competence and cultural sensitivity that we need to understand better, and it is disturbing what we're seeing on that. We of course need to include many more bilingual providers and interpreters in the care teams. We have language access issues throughout America, particularly in California. We've done a lot of work in this area. People still don't call on interpreters when they should. They don't know how to work with interpreters when they're there. They often pull in family members when it's inappropriate, particularly using small children in inappropriate conversations with their parents to do interpretation. So this is an area that needs a lot of work as well. We can also expand, of course, this is the one that everybody goes to first, expand the numbers of traditionally underrepresented minorities in health professions, and engage frontline workers such as medical assistants and CHWs, that's community health workers and promoters, from the community who better represent the community because you get better representation. But these are the ones that have been challenging. So let me go through a couple more stats on those 2 last bullet points. And I have to say that overall it's not a pretty picture. I wish I could report that we had moved the dial a little bit on this, but we just haven't. These are numbers from AAMC, the Association of American Medical Colleges, on graduates from medical school looking at 1978 and 2008, so 30-year difference. Black men, the numbers actually decreased in that 30-year period, from 474, which was already too low, and went down to 429. Now with women, we did a little bit better. It actually increased more than doubled, from 250 to 763. But overall, we're still looking at just 1,100 people graduated in 2008, and that's 6% of the total graduates out of medical school, compared to a much higher number in the general population, more like 11 or 12% or something along those lines. So it doesn't look too good. This is Hispanic or Latino U.S. medical school graduates by year and sex, the same 30-year period. Men, in this case, they did increase. Women increased even more, so that's pretty impressive. But overall, and the overall total increased almost by triple, which is impressive, but still we're looking at a third of what they should be. So these numbers, they can be, you can shine a light on it any way you want. We've made some movement, but the numbers are still so low compared to the general population that it's pretty disturbing that we haven't been able to really move this forward. And then we tried to look in California in particular because the California Wellness Foundation, the California Endowment are really interested in these topics, so they gave us a grant to look at numbers of men of color in the health professions, because this is an area, as you saw, the women had actually increased over those years, but the men really hadn't or had decreased. So when we look at African American and Latino men in California in MD, that's medical doctor, or DO, that's doctors of osteopathy programs, these are looking at 1995 to 2007 numbers. Again, with African American men, we see the numbers decreasing. Now, it's using different indices. We use a proportionality index in these numbers. And we're comparing the number of people who are in the professions, in these educational programs, compared to what we should see in the general population. So if you see a number like 0.44, that means that Latinos there's only 44% of the Latinos are represented in the medical profession compared to how they should be in the general population. So it's a slightly different way to look at to use the numbers. It's supposed to be a little bit easier. Sometimes it's more confusing. Sorry about that. We're using different ways to try to see what works with people. But again, African American numbers have gone down in California significantly. And this is partly because of policy decisions. We had a proposition, we had court decisions that really had a chilling effect on the medical school enrollments and graduation rates. Latinos have remained flat and gone down a little bit in medical programs and DO programs. Asians have gone up. We've included those for comparison numbers. And just a little point about the African American number, that one for, let me show you dentistry. This is dentistry and pharmacy. African Americans went up in the dentistry programs a little bit, but it's mostly because of the decreasing proportionality of African Americans in the California population. So again, statistics can be a little bit misleading, but the African American population has shrunk proportionally to the Latino and other populations in the state. So that slight increase is really pretty small. In fact, it represents, in terms of ends, there were 6 people in the dentistry programs who were African Americans in 1995, and there were 9 in 2007. So we're not talking about any great numbers. So I personally try to balance a lot of these data geek work with some qualitative work and looking at innovative models, because I find inspiration in some of these models. We're looking at primary care models around the country now that are using integrated care teams that rely on people and teams of people that are drawn from the community in addition to outside the community to provide care. And we're seeing really good results. We're very curious about these innovative practice models. I'm using today one of the 14 highly successful models that we've profiled and that we're sharing around the country right now. And I'm using this one intentionally because it's a Native American program up in Alaska. It's the South Central Foundation clinic up in Anchorage. It's a level 3 patient-free home. They're affiliated with the local Native hospital. They took over services for the Native population a couple decades now ago because IHS really wasn't providing the care that they wanted. So the tribe took it over and really turned things around. That's an understatement. This place is now internationally renowned for its care model. It is phenomenal what they've done in terms of clinic outcomes. So the patients are much better. We're seeing much better clinical outcomes, financial sustainability, and also good for the workforce. And that's what I want to profile because they're workforce, these teams are co-located together, so the doctors or the provider, actually they use nurse practitioners, PAs, and physicians as providers, but they are sitting on a team with a couple of medical assistants, with a nurse case manager, with a behaviorist on every single team, because they noticed that in Alaska, the rates of suicide, of substance abuse, of domestic violence were so high, they needed a behaviorist on every single team. Pretty much everybody who came in had some issues. So there's a behaviorist and a dietitian as well on every single team. So these teams are co-located together. There are no doctor's offices or nurses' stations. They sit collectively around a table. It seems like a small thing to do, but it has changed the face of care. It's really improved the way they're working. They also have a very strong onboarding program that allows and encourages and actually expects all workers to have a professional development plan, so they are growing throughout the professional career within the organization, and they encourage getting additional degrees. Over 50% of their workers are Native American population, so they have a significant investment in their workers. This is one slide where you want to see the numbers go down. This is turnover, staff turnover at South Central Foundation. The green number, the green bar is the Native American, Alaska Native population workers, and the blue bar is the total turnover. Significant reduction in turnover rates. You don't see this in any other setting in this time. This is like a 4-year time period. Phenomenal because of their investment in their workers and this team effort. So we're really excited. We're very excited about the model up there. Also, just as an aside, they do not refer to their customer owners as patients. Everybody is a customer owner because the tribe owns the clinic, so everybody who visits that clinic is a customer owner. You never hear anybody referred to as a patient. And that, again, it felt a little bit awkward at first. After a while, it feels really good because everybody's everybody's invested in the care. That's the first thing that we can do. We can do the things that we've been doing and do them better. Second big thing that we can do around healthcare professionals is to redefine health interventions and not just be defining them as acute healthcare interventions. This means that we're looking at defining early childhood education opportunities as a health investment. I made this slide a few days ago. I got called to this panel fairly late in the game as well, and I was on vacation last week. So I was making the slide early in the week, and I wrote that down, and I thought, I've got to find somebody who's doing this sort of thing. And within hours, it's like when you put the question out to the universe, sometimes you get an answer right away. Within hours, the NBC News had this little story about Dr. Dreyer from New York, who has now called childhood poverty a healthcare crisis. So he is my latest hero. I have yet to meet him, but he's my hero of the week, because he sees that childhood poverty is affecting and having such a significant impact on the population. The poor children who are not able to get education then start kindergarten at a severe disadvantage and can never have a very hard time catching up. So those things, again, linking policy like that with healthcare makes a big difference. Also things like looking at neighborhood design, parks, grocery stores that have fresh fruit, those sorts of things, and employment development, offering employment and work opportunities for the neighborhoods have a role in healthcare. We know that big picture, but not enough people are saying it. The California Endowment is one example I would point to. They've made millions of dollars of investment in 14 communities in California on exactly these sorts of things, making parks accessible, making communities safe to walk in at night, helping to develop workforce opportunities and educational opportunities for the population. And finally, connecting health professions with policy work, and not just for lobbying Congress for higher pay. To talk about some of these issues that do affect healthcare and health status. Some of the things are around workforce distribution. I have stacks of papers and data for you if you're ever interested looking at. There are no shortages in healthcare professions right now. We just have a maldistribution problem. We have more healthcare professionals than we've ever had before, not only in terms of numbers, but in terms of ratios. And we have them, but we have them in the wrong places. And that includes primary care. Although U.S. medical school graduates are not choosing primary care as much as they have in the past, foreign students are, and we also have doctors of osteopathy who are choosing primary care more often than specialty care. So those numbers are outweighing the lack of interest by the U.S. medical graduates. That's an important, nuanced fact that goes against the headlines that you hear, but it's important to know that. But the problem is we've got doctors who are going to the well-served areas already. For every doctor who goes into an underserved area, we have 4 who are going into already well-served areas. So we've got this maldistribution problem that's getting worse over time. So the maldistribution problem, we need to look at encouraging people to practice in the right places, and we look at encouraging people who are in some of the professions that do have better representation, such as CHWs, such as medical assistants, such as physician assistants, where you do see a real good participation rate of African American men, for example. Include create career opportunities and articulation patterns for them so they can move up in the professions. Also involving people, health professionals, and educational policy as well. My takeaway themes are integration, looking at integration across the professions, across systems, across primary care and public health policy, accountability, doing what we say we're going to do, holding ourselves accountable for evidence-based policy decisions, that's real important, and being creative. We cannot practice healthcare the way we were doing it 10 years ago or even last year. Things are changing at breakneck speed. We know that we need to do it a little bit better, and there are examples out there, models that we can point to, and I'm happy to talk with you more about that as we go forward. I'm going to close with a really short story about my daughter. When she was 3, we go to the doctor's office, we walk out, and she says, "Mommy, can boys be doctors too?" And it was not my intention to only see female physicians, but that had just been her experience. She'd seen her pediatrician, and my primary care doctor happened to be a woman. So I am hoping that we can think creatively and think big so that it's only a few years down the road that we have a lot more children saying, "Mom or Dad, can white people be doctors too?" So I'll close with that. Thank you for your time and attention today.
Good morning. Good morning. I just wanted to make sure you were all awake on Saturday mid-morning. Thank you for sticking it out. As was mentioned, I think this summit has been a tremendous success. I've been really pleased with both the panels as well as seeing the diversity in the audience. Because for many of us who have been working in this area of diversity and trying to really look at what we need to do in this area, sometimes we get a little bit jaded and we say, we've been talking about this for many of us, depending on where we are in our career, 20, 30, 40 years, and we go, is anything changing? And I can tell you that I have felt through the dialogue and discussion here from hearing some of the work that's going on that I think we are at a different point in time. I think our challenge will be what we do with it. And that's how come I think the importance of bridging policy. And so I really want to thank the Congressional leadership that is here for moving ahead with this summit and for us to really reflect as we wrap up what are the appropriate next steps. Because it really is that bridge between what the real world is, what's really happening in the needs, and policy that we can tremendously change this country. So thank you. And when I was speaking with Congresswoman Bernice Johnson earlier, when I was the regional director in Dallas, I became quickly aware that the Congresswoman from Dallas was the only nurse in the U.S. Congress. So I made sure to go pay a visit early on and introduce myself because again, it was really good to see a nurse. I was there in a policy position as part of an executive branch, and she was there as an elected official. And again, I think the importance of all of us connecting and moving the pieces ahead. So thank you very much for the opportunity to be here. I'm going to have some data, but I'm going to talk really more overreaching and more strategically about where I think we may be and what we need to think about. Because, quite frankly, we had a lot of dialogue and discussion yesterday about the Affordable Care Act and what's out there and the wonderful opportunities. And I can tell you that one of my biggest fears as we've been rolling out, excuse me, allergies as with everybody else, as we've been rolling out the Affordable Care Act, is that workforce is core to its success. I don't know about all of you, but what I often think about right now, thank you, is that I think it's wonderful that we have coverage for everyone and that everybody will have access to coverage. But we all know, those of us in this room know, coverage doesn't equate to access. And people who have had coverage have had challenge getting access. What happens now when we add all this new population, excuse me, in to get care? It's really going to be a major challenge, and I think it is the cutting edge issue that this country and that this state needs to start focusing on. Because we can talk about getting care, but if we don't have the workforce to provide the care, we're going to not move ahead very successfully. So, as we know, the United States system, including New Mexico, is changing with the implementation of the Affordable Care Act. And the number of health professionals and their maldistribution throughout the state and the country cannot adequately meet the increased demand. And, you know, it was an interesting kind of bridge just as the previous speaker closed and I come on, and that one of the challenges we all have right now with workforce issues on health professionals is the data. The data, the data, the data. Because we have all kinds of data, but it is in so many varied forms. It's collected in so many different ways. There's not great standardization that oftentimes it's really hard to get a picture of what we're looking at. And so, yes, there is oftentimes a thought that we have more than sufficient health professionals or more than enough nurses. And yet, when you look at what's happening with providing care, it's not translating. So there's a real disconnect there, and so that's why I think it's going to be very important, and look forward to the release by the center of at least New Mexico's workforce data issues. So we've already talked about the whole access to care, but we also have heard over the day and a half of the summit about the trust of communities and seeing people that reflect them. And so we do know that we really need to continue to work on a workforce that reflects the changing demographics in this country. And I know I myself, as many of you in this room and many that have served on the panel, often have found ourselves in that position of being the only person of color in the room or at the table. You know, it was referred to earlier about Dr. Lumpkin from the foundation saying, you know, that he wanted more policy people that looked like him around the country because he oftentimes was the only one. I also, in my journey over the last 35 plus years as being a nurse in policy, have often found myself as the only person of color, or even more specifically, and oftentimes the only Hispanic. And so it is still a very critical issue that we need to focus on. So what I want to do is just provide a quick picture here of what we're looking at as far as nursing and the demographics of national versus New Mexico, or comparing it with New Mexico. And again, those of you that are from New Mexico, I think when you look around the delivery system in the state, or if you've been in any hospital, you look around, and I know I oftentimes, when I talk about the lack of numbers that we have of Hispanic nurses, I'll use that as an example, people say, oh, we have a lot of Hispanic nurses in New Mexico. Yes, we probably do compared to other parts of the country, but it doesn't mean that we have enough of them, and that also then leads to that whole issue of maldistribution. We may have them here, but what about where we have other populations, whether it be Hispanic, Native American, or African American in other parts of the country? Do we have health professionals who reflect the population? So I would just point out here, as you take a look at the numbers, and again, I think it was mentioned earlier regarding the low numbers. If you look at the national percentages as far as nursing goes, American Indian or Alaskan Native, 0.5% of the nursing population, while in New Mexico it's 3.3%. A little closer to what the population is, but in New Mexico, Native Americans are 10+% of the population. It shows a lot of work to be done. The Asian Pacific Islander, 3.7 at the national level. New Mexico, 2.3%. The Black or African American at the national level, 4.9% of the population. In New Mexico, it's 1.4%. The Hispanic, this is where you can see, again, at the national level, 2%. That figure still just blows my mind when I go around the country to see that of Hispanic RNs, they're 2% nationally. While in New Mexico, they may be closer to 20%. And so this, as you can see, comes from the Board of Nursing, and it's from 2012 data for the New Mexico data. The national data came from various data sources, and so when I mentioned the challenge we have is a lot of it depends on when the data was collected and how it was collected. So I found it a little challenging, and that's why I'm looking forward to when the Workforce Center releases their data here, that hopefully we start getting a bigger and a cleaner picture of what that actually looks like, because it's oftentimes hard to really work on this. Having said that, I'm a firm believer in not waiting for the perfect. This still gives us the picture, and from the policy perspective, it helps to highlight what the issues are. So I really want to emphasize that. So thinking about the changing of our healthcare system and thinking about what the needs are, looking at advanced practice nurses, nurse practitioners at the national level, when we start talking about providing care in a different way, I think we really need to think about, look at these numbers. 10% of our advanced practice nurses are from racial, ethnic, minority backgrounds. We truly need to start focusing on that advanced practice level of nursing. And I'll talk a little bit more about that as I go through my presentation. 11% of nurse practitioners are minority nurses. So what does it look like in New Mexico? Again, sources from the Board of Nursing, the New Mexico Board of Nursing. And it shows here that, again, we're doing not well, but we're doing maybe a little better than some of the national data as far as our advanced practice nurses. However, let me also mention that it's very important, and I think this is what gives me hope, is that it was only recently that the New Mexico Board of Nursing, a state that, as we often say, is a minority-majority state, only recently started collecting data by race and ethnicity. I think that's a very important point. So we've talked about all these disparities for 20, 30, 40 years, yet we never really knew, we were never able clearly to define the issue or the problem. The same thing happens with health disparities. We now are finally moving towards a standard collection of race, ethnicity, and language in patient care. Well, how were we going to treat people culturally sensitive and look at culturally appropriate interventions if we didn't know who we were caring for, correct? That is what gives me hope. Having said that, we need to assure that it is done appropriately and that it is spread, because that is where I think we're going to be able to really start moving ahead in the future in this area. What about nurses with advanced degrees? At the national level, 11% of Black nurses have master's or doctoral degrees compared to 10.4% of Caucasian nurses and 8.4% of Hispanic nurses. I tried looking for some other comparative data, but it was challenging to find it, that some data that wasn't very dated. And so, again, this is an area we need to look at. So, moving on to the RN license in New Mexico, again from the Board of Nursing, I want to use this as a picture to show you that we have an aging nursing workforce. If some of you haven't noticed that, we're there. And we need to focus about it, particularly with the changing healthcare system. When you take a look at this and just look at this bar graph of the RNs in New Mexico, look at the 50 to 60 and 60 to 70, you know, just right in those ages right there, how we're prepared to lose a huge cohort of our future nursing workforce and why we need to really focus in this area. What's happening, and one of the challenges and one of the things that I want to make sure to just quickly articulate is one of the issues and challenges we've had in nursing is that it's one of the few health professions that we've allowed people to enter at such different levels. Nurses can come in as licensed practical nurses, which has been good, and it was started at a time when it was needed to get those clinicians at the bedside. There is the ability to start articulating and moving on for the RN degree, but in nursing we've had the 2-year degree, the associate degree, we've had the bachelor's degree, now we talk about advanced practice. That has been a challenge in really getting nursing education support to be appropriately funded for that articulation and transition that needs to occur. And I want to do a shout out to the New Mexico nurse educators in that they have come together in this state as part of a New Mexico Action Coalition and the Center for Nursing Excellence to really focus on that, because we're not going to be able to solve this issue by every college or every school doing their own thing. And I can tell you that they've come up against some challenges. No surprise when it's due to funding and politics, in that the leadership and the curriculum, they're able to come together on what they need to do to allow for better nursing education in this state. But, you know, oftentimes the president of a university might say, well, I don't want to let go of my piece of the program, or I need this funding for mine. And so I'll just put that out there. I'm not going to dwell on it, but it's how those types of issues become barriers for us as we look at workforce. Just a very quick snapshot of nursing licenses by gender in New Mexico. Again, no surprise, it's been predominantly a field where women have gone, and we have not made many strides in the area for more males. And what I also just want to say regarding the nursing data in New Mexico is that the data I was showing you is that those RNs and LPNs are currently working. We know that we also have many nurses who have retired but have still maintained their license, and nurses who are licensed but not currently employed. So as we look at the nursing workforce for the future, we need to take a real look at what's happening from a policy perspective in that area, figure out where these people are, what it would take to get them prepared to be able to practice, and what, how we would support that, because we're never going to be able to produce the workforce that we need for the future. I talk briefly here about nurse practitioners, and for Congressional people that are in attendance with us, just for you to know, New Mexico was one of the first states to have the most expansive Nurse Practice Act that allowed nurse practitioners to practice independently. And that happened back in the mid-'80s. And that was due to being a rural state and the needs that were there. But again, it has not truly allowed them still to practice fully as they need to. So we know that we have a shortage of NPs, and even with PAs, their scope of practice is not the same as nurse practitioners in New Mexico, but they do have prescribing authority and can definitely play a very vital part in our healthcare delivery system. So, I'm sorry, I just wanted to point out though that, we hear that there's not a nursing shortage, and yet many of you have probably experienced either young grads coming out and not being able to find positions, or know many people who want to become nurses but can't get into a program. And those are some challenges that we also really need to look at from a policy perspective. What's happening regarding the nurses not being able to find jobs is that due to the economy, it's very clear that many nurses who were not in the workforce came back in. And so therefore they are there, but we know it's a temporary. So we cannot go into a lull and think, well, we don't have a nursing shortage, we don't need to produce more. Because we do know that we still have a nursing shortage, both in the state and at the national level. It's just a temporary blip in the screen, so we can't rest on our laurels. And so we do need to really look at that and focus on it. And of course, the maldistribution, as was mentioned. So what I would like to leave you with as part of a policy summit is, what is the issue and how do we pull these pieces together? We all know we need a more coordinated approach to healthcare delivery. And we are all working on developing these healthcare delivery models that target the level of care to the patient need. We cannot continue to have a delivery system the way it's functioned in the past. Having said that, we must allow providers to practice to the full level of their license. So those are some policy issues I think that are going to have to be looked at the national and at the state level. We also know that probably half of the population is healthy and can be cared for by NPs and PAs. There needs to be a cultural change. We need to think about messaging, about, we need to let people know that these providers are well-trained and can deal with their needs, and that it doesn't always have to be an MD. Because we're never going to have enough physicians. It takes longer to train them and it's more expensive. So it's a cultural shift that we need to work on. And because we do know that these nurse practitioners and PAs can help mitigate that shortage. We know that people with chronic disease, take a disproportionate share of healthcare services, and they can benefit from coordinated care. We mentioned earlier a treatment team. We're seeing this in the future. That means changing how we train health professionals so that they think in that way. We need to just develop a smarter delivery model system, and we need to also recruit and retain that workforce to reflect the population. We know loan repayment and other financial assistance programs have been major incentives. Many of these have taken severe hits in the most recent past. We know for these underserved populations, it's critical for them to be able to go on to school. We need to, now that we are starting to get better data, target the recruitment to those areas. We need to look at developing pipeline programs, helping them to develop a workforce, and that we really start before high school. If we wait till high school, it's too late. We really need to start at mid-school and look at, community clubs, career clubs. I don't know about you all, but I grew up in the day where we had health occupation clubs. We don't see that anymore. We need to start getting people more engaged and involved with that at the community, and really prepare our young people to go on for higher ed. support health professional career high schools. It's a beginning to get to where they need to go. We know that we need to increase the number of bachelor level nurses, and that's probably a takeaway for this group, is that we have a lot of RNs, but you have to have that BSN to go on for advanced practice. We need more faculty. We need to really focus on what we need to do and how we will fund that type of program in the future. And all of us just need to work on those regulatory and practice barriers that keep people from practicing to their full scope of license. And really continue to push if it's not happening, because I know New Mexico is not unique. I don't know that all state boards of nursing are collecting this data by race and ethnicity. We really need to start looking at that data. We need to start bringing together higher ed as well as our education departments at the school. Somebody mentioned yesterday about bringing other people to the table. I think the one message I would leave for this audience is that this was a very successful summit, but about bringing those other people to the table, we need to start talking beyond healthcare. We need to get higher ed and education at the table, and the community as we talk about these issues, because that's how we'll truly change the workforce to reflect the population. So thank you again very much for your time.
Well, still good morning. Not sure for how much longer, but I want to thank you all for being here and sticking with us. And I know that I am between you and lunch, but I have some pretty, I think, exciting programs that I'd like to share with you today. So I'm going to talk to you about the programs that are called Hope, Enrichment, and Learning Transform Health in New Mexico. But first, we're going to go back to a little bit of background. And I know that several of you, many of you were here yesterday, and you heard Chancellor Roth talk about our Vision 2020 for the Health Sciences Center that says, working with our community partners, the Health Sciences Center will help New Mexico make more progress in health and health equity than any other state of the nation by the year 2020. And we believe that diversity is essential to achieving Vision 2020. It's key to excellence in healthcare for our nation. We know, and we've heard today, we know this, that a diverse health workforce is a key strategy to eliminating health disparities. We know that diversity brings better health outcomes in general. We know that it enriches our educational and our work environments, and we know that it prepares effective health providers for multicultural environments, multicultural populations. So, as we look and we know that we're lucky, we're one of 4 minority-majority states in the nation. And this actually is a tremendous opportunity for us to be creating and sharing models that will improve the health care for an increasingly diverse nation. Now, unfortunately, though, and what we've seen today and what you all know is that we do not have the health workforce that's representative of a minority-majority state or of the nation and the populations that we need to serve. We also have, as many of you are very aware, geographical, socioeconomic. We have our health profession shortage areas and in this state. So what happens here is we have lots of challenges. And here we have, again, we're saying a state with 32 of our 33 counties are health profession shortage areas. As Pat, as Catherine gave, all of us know, this is not just about physicians. This is about health professionals at the level of community health workers, our nurse practitioners, our physician assistants. This is everybody working in interprofessional teams to really start changing the way that healthcare is provided. This is really essential. So we believe that it is extremely important that we grow our own diverse health workforce. So I know we're a society and we always want, like, okay, we want everything right now. But it's so important, and I know that Pat was saying it, and I did not pay her to start saying some of this, but she was saying, let's start looking at getting back earlier in the pipeline. It's so important. We've got to start so early and get our youth excited and let them start seeing that here are some of the things that they can be. I mean, we have so many first generation, we have so many students that don't have health professionals in their family. They don't know that. So it's so important, so critical to start early in these programs for students to start getting them and build our own workforce, grow our own, because they're the ones who are going to be culturally and linguistically sensitive and know about what our populations need. So this is very important for us. And that's what I'll talk to you today actually about two of the programs, the BAMD program that we have that is for physicians, and then our Health New Mexico pipeline programs, which are for all health professionals and start in our middle school. And unfortunately, like I won't be able to talk about all the programs and the spectrum of the pipeline that we have, but I will talk about the Dream Makers program, the middle school program, not only because it's starting at at our youngest age that we have right now, but because it's very replicable and affordable and sustainable for our communities. So we see these as national models that can be, again, replicated and sustained in across the nation. So we're going to start with a little bit of video clip here on the BAMD program.
After successfully completing the undergraduate portion of the program, BAMD students are guaranteed a spot in UNM School of Medicine. That's also where we found Pavan Angadi, a third-year medical student from Clovis, New Mexico. HSCTV first met Pavan 3 years ago in his UNM dormitory, which he shared with other members of his BAMD cohort. It was one of the program's first.
I didn't know it at the time, but now looking back on it, I realize how good of an opportunity BAMD really is, and I'm very thankful that I did take the opportunity.
So is Ryan Mouse, a BAMD student from Albuquerque, now enrolled in medical school, who is as enthusiastic about the program today as he was during his undergraduate years, which provided not only a sense of purpose, but focus.
Even though it is really hard and you're putting in a lot of work and a lot of effort, you have much more of a sense that what you're doing is meaningful and you're enjoying what you're doing and you're interested in it.
Like other BAMD students, Ryan and Pavan are excited to one day practice medicine in New Mexico, and that's the goal.
When you're applying to the BAMD program, they have their mission statement clearly stated, and they want doctors in rural New Mexico, and that's one of my goals, is to go back and serve rural New Mexico, just because that's where I grew up, and that's kind of what I want to give back to.
So now I'm going to tell you a little bit more about that program, and too bad I can't maybe I can walk and talk with this. I'm a walker and a mover as I talk, so I don't know, hopefully I won't blow your ears out. Okay, so the BAMD program, I'm going to tell you a little bit about it. So this program is a partnership program between the School of Medicine and the College of Arts and Sciences. And it has as its primary goal to improve the health and well-being of the people of New Mexico. And the way that it's going to do this is to to address the physician shortage needs. So we have increased our medical school class from 75 to 103. And then the way that we're going to achieve this is we are going to get a diverse group of our New Mexico high school seniors and have those students who are committed to practicing in the areas of most needed. So this current update, we started in the cohort of 2006, so we're now, actually this year is our first year that we have the full cohorts, 4 in the undergraduate, 4 in the School of Medicine. We'll have the large cohort, the first one graduate this fall of the spring of 2014. We're very excited about that. But when we were doing this program and we're saying, well, how do we know that these students are going to go back and practice in our rural communities, which is what we want? Well, we had to look at the literature, we had to look at all the studies, we had to say, well, what are these predictors of someone going back and practicing in a rural area? Well, first of all, if you're from a rural area, you're more likely to go back and practice in a rural area. If you're a minority, you're more likely to serve minority and underserved communities. If you train in a rural or underserved area, you're more likely to go back and practice there as well. And then if you graduate from a primary care training program, you're more likely, again, to go back and practice. So these are the premises that we built this program on, the curriculum and all the parts of it for the students. So what you'll see here in our curriculum, it really focuses on the healthcare needs of New Mexicans. So the students have their own health, medicine, and human values major with 3 tracks, and they also have an integrated health seminars that go throughout the 4 years. And so these are seminars that are telling them all about the needs of New Mexico, the economics, the culture, the diversity, the ethics. So those seminars are for the BAMD program. Then you go into the supportive services that are offered. And let me tell you, there are about 46 BAMD programs across the country. This program is unique in that it is 100% funded by our legislature. So 8 years we went to the legislature for recurring fundings for this. This was the top priority for the UNM and the Health Sciences Center. And then what it provides is these incredible support services. We all know the tremendous cost of higher education, and we know the poverty that we have here in New Mexico. So this program, these are top students from across the communities. These are the top students from every community, and so a lot of them have Gates Millennial, they have the Regent Scholars, they have all sorts of scholarships. But whatever they do not have, this program covers all the other basic educational needs. It also provides housing, it provides books, it builds cohorts, they live together for the first 2 years. And then, unfortunately, you know, we have a university where, unfortunately, our students who are pre-med have a ratio of 1 to about 600 to 700 in the advisor to the students, pre-med students. In this program, these students have 1 advisor for every 2 cohorts. And they also have the tutoring, they have MCAT prep courses, they have supplemental instruction, and it's just incredible support services. And then they have this participation. Remember we were saying one of those determinants was if you train in a rural community. The end of their sophomore summer, they go back in a rural community, and this next map will show you they go back and they do a public health and clinical month there in a group of about 5 or 7 students. And they go back and they determine, do a needs assessment with the community, and they decide what are the things that are important to this community and what can they start working on. And they do some projects with those. So you can see what some of those have been. And these are just a couple pictures of the students out in our communities. And then the communities are so excited, and so we have some great media all the time. They're doing these wonderful articles on the students and what they're doing in the communities because they're very proud of that and they feel that it's very meaningful. They're doing it together, and it's back to, again, what Pat said, I think what all of you have said about being meaningful to communities and working with our communities. So let's go back and look. So we talked about if you're from a rural area. So have we succeeded? Well, 2/3 of the students in this program from 2006 to current are from our rural underserved areas. If we look at the ethnicity, I'm talking about the minorities who serve minority underserved. Yes, we have greater than 2/3 of our students in the BAMD program are minority students. So yes, we have been very successful. And then this is just showing you a map, again, where we have broad representation from across New Mexico from our students in the BAMD program. And we do believe that we are serving New Mexico 1 position at a time in this program. And you know what I'll tell you, so Quinn Ann up at the top and then John, we had 2 students that graduated early. They did the undergraduate in 3 years. So Quinn Ann's going to be in Santa Fe. They both graduated last year. She's doing the family medicine program in the community. And then John's doing general internal medicine here, and then he's heading off to Mayo for anesthesiology. And then we'll be seeing them back here when they're done with residency, serving our communities. So we have a few more years till we see now and start seeing a tracking when they come back to serve. So the next part of the programs I was telling you about, now that we start talking about more the health professional programs, are these Health New Mexico pipeline programs, Hope, Enrichment, and Learning, Transform Health in New Mexico. And we have programs that go these Dream Makers that I'll talk to you a little bit more about. We go from middle school Dream Makers to high school Dream Makers Plus during the academic year. We go into a Health Careers Academy in the summer for ACT prep, academic preparation, health careers exposure, into an undergraduate health sciences residential program, bringing our incoming freshmen onto a campus so they can acculturate and know what it's like to be on a huge college campus. Always continuing across all of these is academic preparation and the health careers exposure. You go into a ClinEd program and we put them in the rural communities for 6 weeks and immerse them there to not only shadow and understand how a clinic works, but to get out of those communities and understand what it is to really practice in the needs of a community. And then we have the MCAT, PCAT, and DAT. And for those who may not know, in the health professions programs, you have to take these exams before and see what score you get and how competitive you will be. And unfortunately, our minority students do not tend to do as well on the standardized tests. So we offer Kaplan and mock interviews and how to prepare your application and do these summer programs as well. And then there are 2 post-bac programs that are for pharmacy and medicine, meaning these students went through the application process. The pharmacy and medicine admissions committee said, God, these will be great pharmacists and doctors. They just need a little bit more. They go into a conditional 1-year program. They pass that, they're in pharmacy and medicine the next year. So those are just like the other spectrum of them, but I want to draw your attention to the reciprocal information corridors, because you're probably thinking, well, what the heck is that? Well, what that means, and what we realized after a while when we were doing the programs, which is great, and you're reaching out and doing all that, we weren't really sure, and we realized that how do we know that what they're learning and what they're doing in these programs is actually going back to their families, going back to the communities, and are we really hearing what the communities and the families are saying is important to them too? So now we make sure that that's really a closed, a circle and a cycle there for us is this reciprocal corridors we think is just essential to these programs. And we also feel that the foundations of this program include the community-based programming, cross-cultural awareness and multicultural enrichment, all in all the programs from middle school up, service learning, and then asset-based programming, so that students are really aware of their values for language, their culture, their identity, their communities, and always at the center of this is our families, our students, and our communities. So let me quickly just show you as well here. So we were talking about, in blue are the percentage by race and ethnicity in our program of the students that we reach, and the red is the percentage in the state. So you can see that we are certainly representing the diversity in this state, in the children and the students that we have in these programs. And then here, I'm sorry this doesn't show up as well, but this just gives you an idea of some of the Dream Makers, this middle school program. So Pat was talking about, what about those, I don't know what you call those, career club programs, but this is an after-school health careers program that is incredible because what happens is it's not expensive, you get a couple teacher sponsors, you get a community liaison, and someone in the community who knows and can help the teachers bring some of the health providers in, and you get them to do hands-on interactive activities. You do math, you're doing reflective writing, you're doing all the other academic preparation, but you're starting to tell kids again, here are some of the things you can be. And what's pretty amazing about these programs, I'll tell you, with the different colors, you can't really tell here, but they're where we are in the community and then where we're going to be in the next year. But what's so nice is we know that so many of these students in the rural communities, their only contact with health providers a lot of time is when something really bad has happened. So now all of a sudden they're there and the health providers are teaching them things, they're learning things, it's exciting for them. And the health providers were really excited because they said no one had ever invited them to the schools before. So we're getting the education system, the provider, the health provider system together, and it's really created an incredible opportunity. And if you look at, again, sustainability, so the supplies that are at $500, $1,000, the local businesses or the hospital will pay for. The tour that we bring them for back to the Health Sciences Center so they can see what it's like to be on campus and start picturing themselves here, we will always pay for that. The community liaison will work with our area health education centers and our NewMexico MESA, the mathematical engineering science people. And they say, this is part of our job anyway. We'll be that community liaison and you don't have to pay us. So here again, now you're slowly now saving the money, becoming sustainable, and using that money now for another program. And let me just tell you, these programs, these health career programs, are funded by Title VII and Title VIII funding for nursing and for health professions. They are, as our Congresswoman Johnson knows, the only federal programs that are increasing the minority representation in our health workforce, and they're the only federal programs and funding that actually teach providers to work in interprofessional settings and to care for special and underserved populations. So the Title VII and 8 fundings are critical, and those are funds a lot of times that we just don't, that are kind of, they go out, they come in, they go out, they come in. We're funded right now, we're lucky to be funded, but you know, that's something that's incredibly important for the diverse workforce, or those Title VII and Title VIII programs. So I'm going to be ending here, and I'm sorry because I know I'll go a couple minutes because I have just wanted to end with a couple stories real briefly. Michael Manzanares is from Español, and he was in the DAT program, the one for the dental prep program before he applied to dental school. So he's saying that, you know, this program will have a lasting impact on his community in the near future because in 3 years, he wants the opportunity to go return to his hometown and provide high quality dental care. He was successful, he got into Baylor, he's starting his 2nd year of dental school right now. And then I thought the nice thing, that it's always nice instead of like kind of me talking, we're lucky enough to have Anissa Gallegos here, who was in our Dream Makers program and got into our BAMD program. And I want her to just tell you, just, you know, in her own words, what she thought, because I just think that's important to actually hear from our actual students. And
thank you, it's great to be here. So my name is Anissa Gallegos, and I'm from Rociada, New Mexico, but I went to school in Las Vegas, New Mexico, so quite a commute every day, but it was fine. And I joined the Dream Makers program as a freshman at Robertson High School, and I was in the program all throughout high school, so a total of 4 years. And since the 3rd grade, I would just like you all to know that I wanted to be a teacher. Like, my parents would ask me what I wanted to be year after year, and it never changed. But after being in the program, it changed almost, you know, just after about 1.5 years of being in the program, and my parents were completely surprised. But it was just because my eyes were suddenly opened to the fact that there's so many opportunities in the healthcare field. There's so many fields that you can go into. It's not just the people who check your reflexes during physicals. And so I just really enjoyed that we had these physicians from our own community and neighboring communities who came and actually told us about their stories, what made them want to be the doctor that they were, how long it took them to graduate, what classes they would recommend us taking since now. And then we made things like chapsticks, or we practiced wrapping ankles on our peers. And it was just really interesting. And in addition to that, we did other things that were important, like building a resume and becoming CPR certified, and going out into our community and doing service learning, and learning about what our community really needs. And soon I knew that I wanted to be a healthcare provider and return to Rociada in Las Vegas and practice medicine. And in the meantime, I would also be a teacher. And it was just, it helped me find the goal that I really think that I should be doing. And now the BAMD program is actually helping me to execute that goal. And I just think it's a really important program. I actually wish it was offered in more areas around the state, so that way my sister, who goes to school in Santa Fe, could actually have all these amazing opportunities that I do, and maybe stay away from boys a little bit more. But sorry. It's just a really great program, and I'm forever going to be grateful that it redirected my life. Thank you.
So I end with one last little short story here of Erica Garcia. And Erica is initially from Clovis. She was in our ClinEd program, the one that puts you in a rural community for 6 weeks, and also the USEP program, the one that brings incoming freshmen onto a college campus in a residential area. So Erica says, you know, spending 6 weeks in a small town during the ClinEd program made her aware of the health disparities in small and New Mexico rural communities. And she said the biggest impact that she immediately felt in her community is she's filling a cultural void with Spanish-speaking individuals, especially females. So this one, I just get this warmest feeling in my heart when I see this picture. So this is Main Street, Portales. Erica went back to her community near where she is to practice medicine now. And she went into our School of Medicine, she went into our Family Medicine residency, and now she's back right near her hometown, by her parents, by her family. And she sent this picture because she got there and they had this banner across Main Street, Portales, and she had all these little kids coming up and they were telling her, Doctora, you're going to be my doctor. I saw your face up on Main Street. And so she was just so excited. And I love this picture. I just think it's incredible. This is what it's about. And the way this also closes the loop is this year, Erica, this last summer, took one of our Clinet students in and precepted them, one of the students that goes into a rural community. So we come full circle. And I mean, this is what it's about. It's growing your own, so they come back and they work and they teach and they're part of our communities. And they know what we need in the communities. So anyway, I want to thank you. I know I went over my time a little bit, but I really appreciate it, and I just think these models can really be replicated anywhere in the nation, and certainly throughout New Mexico. Thank you for your time.
We have now come to the question period, so there are mics here.
I speak pretty loud, so maybe you can hear me. That's what being a teacher does. I'm Marie Lobo, and I'm faculty in the College of Nursing. And I just basically have a comment, and that is, we also need to have faculty who look like our students. And we need more of a push to get nursing faculty educated with PhDs, nursing faculty of color. And we have more support for people going into clinical positions than we do in academic positions. And if we want to keep increasing the workforce, we need more people that don't look like me. We need people that look like the students we're trying to recruit. And any support that we can be given for that, I think, is very important if we're going to change the workforce. Thank you.
Thank you, panel. I'm smiling because I work with many of you, so you know where we're coming from. We're still having discourse on Titles 1 through 3 of the PACA Act as it relates to personal healthcare delivery services. And we're still not paying any critical attention to Titles 4 and 5 that actually deal with population health, as well as 4 and 5, which deals with the critical population health proportions. Yes, there is a tremendous concern for maldistribution of resources, but who's really addressing the shortages for allied health professionals and frontline workers? When you look at the Bureau of Labor Statistics, it shows that for every MD, you need 8 to 10 allied health professionals. And when you look at frontline workers, you'll see that this is one of the fastest growing areas in personal health care delivery services. And most of those people are immigrants and children, people of color, who don't have the opportunities to get into a BA or MD program or pipeline programs. And so they wind up being the first person that people see when they come to healthcare systems. So who's taking responsibility for making sure that those folks have opportunities for learning diversity, equity, and inclusion, as well as social justice as it relates to healthcare?
It's a great question. We are tracking that. We now have health professions. There's 200 plus recognized professions in this country, and all the therapy, the technicians, the assistants, and all that, including a number that aren't recognized in many of the states yet. The CHWs, the promotores, there's medical assistants in many places that aren't recognized by the state, licensing, et cetera. But one of the challenges is that the private sector is actually paying attention to this. The private sector programs, we've got several reports coming out this fall tracking what's going on in California, because the private sector has responded to the need for demand, and those are growing professions, workforce groups, and develop programs very quickly, but they're extremely expensive, and they're targeting minority populations. People are enrolling in the programs, and they're coming out with a degree and has huge debt, and they're still going into jobs that are paying just above minimum wage in some places. Now that varies from place to place. We're actually working now with many of the community colleges, because the community colleges have terrific programs, but they haven't been able to scale up as quickly as the private sector has been able to. So that's a challenge. The community colleges need to be able to be a little bit more nimble, and so that they can. Thank you, voice. Community colleges do have good programs, but they need to be able to be more nimble so they can expand and accommodate the need for growth and still maintain their high quality. It's a huge issue, great question. That's another conference, but I just wanted to comment that I appreciate what you're saying.
Thank you.
I think we have time for one more quick question.
Thank you very much. Just a quick question. I was concerned when I was thinking about all the professional preparations of the role of some of these private schools, and I see it especially with nursing, where nurses get their degrees from private school, and then they can't get into the pipeline to the HMOs around here and the, like UNM, because they prefer graduates that are coming from their own system. And I can understand why. My question is, what kind of advice can we give? Because being a faculty that works with many students, about advising them the public course or the private course in terms of an education and what would be their best benefits. This is a big issue here in New Mexico. They're pulling a lot of their students into the private schools, and financial aid is going in that direction.
I don't know that it's an answer to that, but you know, we heard the comment earlier about that the community colleges need to become more nimble. I think all our academic institutions, particularly our public institutions, need to become more nimble. I think part of the challenge we see occurring right now is, and it's a chicken and an egg type issue. It was brought up about the need for faculty. You know, but we need to really start thinking about curriculum and education in a different way, and sort of start thinking about new models of training that might allow for public institutions, because the challenge is many people are applying for the public institutions and are on waiting lists. So I just know people both in the state and nationally that are interested, and I think what's really sad is we're losing a core of people who have the heart and interest, and if our public education systems cannot sort of accommodate some of that, the private sector is going to fill in, and as you say, it's not necessarily the best for some of those students as they come out. So I think it's ongoing dialogue and thinking out of the box about how we can do some of this differently.
One last quick question, Governor.
May I thank you? This is to Ms. Romero. I was in the hospital at the beginning of the year, and they brought some student nurses and doctors, nurses, and they were going around in the rooms, and when they came to me, they were asking, can they, you know, like, do the vitals, things like that to me. So I kind of gave them a hard time. I told them, I don't want you guys to touch me. I don't know who you are. I don't know if you're from the hospital or where you're from, but they introduced themselves. And they looked at each other, what to do. And I smiled at them and I said, I'm just giving you a hard time to know that you're going to be in situations like this, to where a patient is going to be very uncooperative to you. You know, they're not going to want you to touch them. They're not going to want you to look at them. So what you can take back and discuss in your classes, you know, how you're going to handle it when you're in this situation. I don't know if I would just say your program has types of these, how to address these situations to the nurses, the students. But that way when they're in these situations, they know how to handle it. But you know, I just did it to them, to kind of let them know they're going to be in a situation like this. Thank you.
Thank you. How about a round of applause? Our closing panel is some closing remarks from the members of Congress. So I'd like to invite members of Congress up to the stage.
Is it almost, oh wow.
Is it afternoon? Okay, good. Good afternoon. Hey, thanks everybody for hanging in. This is such an important conference. I'm very impressed and very proud that in Albuquerque we have so many dedicated individuals and professionals who really want to make a difference. But I'm also equally proud that these incredible members of Congress are here on a weekend, and I want to do a particular shout out to Congresswoman Lucille Roybal-Allard, who's been here the entire time. And I'm going to have to do more of my accolades for her and her leadership on the Hill, but she's got a flight to catch, and I really want you to have the benefit of having her talk to you about next steps. So please, one more round of applause. Congresswoman Lucille Roybal.
Thank you very much, Michelle. As I mentioned at the beginning of the summit, for the past decade, the Congressional Black Caucus, the Congressional Hispanic Caucus, and the Congressional Asian Pacific American Caucus have worked together as a tri-caucus to explore and to develop policies to eliminate health inequities in this country. This partnership has produced two important traditions: the annual Tri-Caucus Health Summit and the Tri-Caucus Health Equity and Accountability Act, which we call the HEAA, which reflects a collaborative agreement on what is the most current and comprehensive strategy for the improvement of minority health. Each year, the responsibility for Phase 1, which is the summit, rotates among the three minority caucuses. And this year, the Congressional Hispanic Caucus was the host caucus. With each new Congress, the responsibility for Phase 2, the introduction of the Health Equity and Accountability Act, also rotates among the three caucuses. The lead caucus for this Congress then works in collaboration with the other minority caucuses to revise the previous HEAA based on new research, changes in the policy landscape, and updated information from health professionals and advocates, including the information that we get from our annual conference, a conference such as this. This Congress, the responsibility for the HEA fell to the Congressional Hispanic Caucus. And as chair of the CHC Health Task Force for the 113th Congress, I will have the distinct honor of carrying on that tradition. With the conclusion of this 11th Annual Tri-Caucus Health Disparities Summit, we have completed Phase 1 of the Tri-Caucus's effort to highlight health disparities in our nation. Phase 2 is the development of health policies for the introduction of the Health Equity and Accountability Act of 2013. Now, each Congress, to ensure that the bill codifies collective institutional knowledge on the policies needed to reduce and eliminate health disparities. Several hundred health advocacy organizations throughout the country participate in the HEAA working group to discuss the best way to ensure the bill is updated to meet the ever-changing needs of our nation's most vulnerable populations. And I believe that it was put on all the tables yesterday was a list of all those organizations that participated. So each Congress, then the leadership of the HEAA group, working group, also rotates among advocacy organizations. Now, in the 113th Congress, this effort has been spearheaded by the National Latina Institute for Reproductive Health, represented by Natalie Camasra and Kimberly Inez McGuire. And Natalie and Kimberly have been here these last 2 days, busily taking notes to take back to Washington so that we can incorporate a lot of the ideas that came out of this conference. And they are here right now, so if you would please stand and be recognized. I want to publicly thank both of you for convening the HEA working group and for your tireless work and commitment, not only to the drafting of this bill, but to social justice as well. So thank you so very much. Now, a little bit about the bill. The bill that the group has been working on is made up of 10 titles proposing a wide spectrum of racial and ethnic health disparity elimination initiatives. And these initiatives address specific high-impact minority diseases and mental health issues, as well as ways to improve health outcomes for women, children, and family. The bill also includes policy recommendations that improve data collection and reporting, ensures access to culturally and linguistically appropriate care, increased workforce diversity, enhanced technology, accountability, and evaluation, and targets resources to communities striving to overcome negative social determinants. The Caucus is currently reviewing the working group's suggested edits to the HEAA. And I'm sure that following this summit, as I said, Natalie and Kim will have many more suggestions when we get back to Washington. This entire process, the one that I just described, really makes this Caucus bill that we will be introducing very unique, in that it is fully the product of a collective effort of policymakers and health advocates, such as all of you in this room. I will be introducing the bill. Hopefully, I believe the target is this fall. And I believe that there was a summary of the bill, what I just outlined, that was put on all the tables. And I don't know if we have any extra copies for those that weren't here yesterday, but I'm sure we can get, okay. They said that they have extra copies here, so you can talk to them about that. And in closing, let me just say that when we introduce the bill, that we hope to have your active support in highlighting the importance of this health justice legislation, and that you encourage members of Congress to co-sponsor the bill. Because the reality is that, you know, we can introduce all the bills, we can have all the summits, but unless we have that same strong advocacy behind the policy, behind the legislation, it's not going to happen. We cannot be successful without the support of all of you, the active support of calling your members of Congress, asking them to co-sponsor, go to Washington, lobby on this bill. That's the only way that things happen. And so once again, I want to say thank you to Michelle for agreeing to host the summit in her district. As I mentioned yesterday, this is the first time that a freshman has actually hosted this, because this is such a tremendous So I thank you for your leadership on this, and certainly I thank you for your leadership in Washington, D.C. You are so very fortunate to have somebody like Michelle representing you in Washington, D.C. And for one of the senior members of Real Pro, I want to thank Bernice Johnson also for being here. She came, Barbara Lee was unable to make it in the last minute, and she's always a trooper. She came, changed her plans, and was here with us, and I couldn't think of a better person to have for our panel. So thank you so much, Thank you also to the RWJF Center for Health Policy and the University of New Mexico, and all the generous sponsors, because this could not happen without the sponsors, for making it possible for us to convene this very important summit. It has been a very full and invigorating 2 days, and I'm sure that you will all be in agreement that the presentations have really been invaluable, thanks to the outstanding speakers who have shared their collective wisdom with us. And of course, a conference is only as rich as the audience in attendance. So I applaud and I thank each of you for taking time from your busy schedules for the very important questions that you asked. And again, thank you for participating in the summit. And I can assure you that we are going to take your ideas, and because of you, the bill that we will be introducing will be even stronger and better. So again, thank you, and everybody have a safe trip home.
She's amazing. Thank you very much, Congresswoman. Safe travels home. This is what we do. We run out of meetings to catch our planes, and it's an interesting lifestyle. I want to introduce, I know that she's already been introduced to you, Eddie Bernice Johnson, and I hope it doesn't sound trite. We work for you. It's important to us to come into districts to do, this is almost like a field hearing to make sure that you have access to your local representatives. However, it is no easy trick to get out of your district and to come into somebody else's district and to participate in these kinds of events. And the dedication of these caucuses and their leadership, including the Native American caucus, for this particular event, these are the groups that lead all of the social justice efforts in Congress. And I really want to reiterate that. These caucuses lead, protect, and champion all of the issues that have been identified today and all of the issues that look at eradicating poverty and protecting the middle class. It's these caucuses. And Congresswoman Johnson's been doing this far longer than I, and is an incredible champion in her own right, and very respected, and I am so honored to have her here today. And I'm going to ask her to say a few words about our efforts over the past day and a half. Congresswoman.
Thank you very much. I know the time is done for this session, but I want to say that it is not an easy job to be in Congress. It is not an easy job to make all the trips, but you have a young champion here who just joined us. And when you see someone as sincere and as committed as she is, it's hard to turn down if you can possibly do it. So when Barbara Lee called and said this was Thursday afternoon, which is highly unusual to be able to change the schedule that quickly, I said, if Rob Allen's going to be there, and if Lujan Christian's going to be there, then I will make a way to get there. I know the difficulty. You know, Rob Allen followed her father, Congressman Rob, who was into the same issues, standing up for the senior citizens, working people, and people in the health caring positions. And we went together. We're in our 21st year. But there's never a time when jobs are done, when you are dealing with issues of this sort. We know the population growth is changing. We know the essential elements that we need to take care of to make sure that we are answering the needs of people. We are also aware of the problems that come with it. You know, I heard the dialogue on private versus public. Money comes in there. And you know, student loans have not been so easy. We're trying to work on that. We know that when we start falling behind and producing people at graduate levels, it's because many times they're so overloaded with the loans that they have when they graduate with a bachelor's degree. It's difficult to go on to graduate school. we try to deal with that. We're not unmindful of that. So when we stand and encourage young people to go into these professions, it is not because we're not aware of all the things you take with you as you try to enter them. We also talk a lot about diversity. And it is good to see a diversity of faces. And it is important. But the most important thing, it's a part of the healing process of people you're taking care of. When you have patients to come to a hospital or a health facility and they see someone that looks like them, it brings a comfort zone. And in places where we're concentrated often, like NewMexico, different cultures, leaving rural areas, coming to urban areas to access care, it is important that that communication, not just language, I don't even speak Spanish, and I have a very diverse population, but I do communicate. I communicate because I'm genuinely interested, and people can feel it when you are. And so I would say that when we look at diversity, it is very important to look at statistics and how we are gaining more here and gaining more there. But the bottom line is, it is important to achieve the work that we're trying to achieve. And that is making better health status for the patients. Getting the education out there. When people don't have the information how to take care of themselves, and they can look to someone that look like them, that talk like them, no matter where they come from in the world, it is important. And so I want to thank you for being here, showing the interest. I'm grateful to Robert Wood Johnson Foundation for that support. Believe me, when you stand in a body that we stand in every day, pleading on a daily basis for understanding and giving attention and focus to the needs that this nation needs, it's good to come and find a group that's just as interested as you are. And so thank you very, very much. I hope that this conference has been good for you. As far as Ramon Allen is concerned, I feel that she feels very successful because she's done a very good job, and so has our host. So thank you again. Feel free to write. Feel free to tell your friends and neighbors to write. Not necessarily us, but somebody you need to convince to be on our side. Thank you.
Another round of applause for our esteemed members of Congress. Well, you can't really close things out any better than that. I think everybody would agree. So I'm going to be very short and brief, mainly just thanking everybody, as folks already have. In the context of the audience, it's been an action-packed day and a half. I think the challenge that all of us face that we're here in the audience and are particularly here from the state of New Mexico is what's next? I know I've gotten tons of text messages, emails, folks grabbing me in the hallway in between sessions and basically saying, how do we capitalize on all this energy to actually continue the fight and actually try to do more policy work in the context of the RWJF Center and across the state of New Mexico. So those of you that are interested in engaging in that, I think one of the first steps will be trying to capture everything that was discussed in the context of the day and a half that we've had here and pulling out of all those presentations all of the really succinct policy recommendations that were made and drawing that into hopefully a succinct document that we can use not only in terms of federal legislation but also state legislation. So those of you interested in that, let's please collaborate on that effort. The RWJF Center is very happy to be part of that charge, but it will have to be collaborative to be successful. So without going into a long-winded overview of everybody that should be thanked, I think the most appropriate thing is to basically end where we started. And that's by inviting Governor Tafoya from Santa Clara Pueblo back up to the stage to close things out with the closing blessing the same way that we started. Thanks everybody. I hope folks that traveled in have a safe trip back home. Thank you.
Gabe, can I be terrible as the esteemed governor is coming up and add 2 more things?
Absolutely.
All right, but I want the love. Governor Tafoya is fantastic. I promise I won't be long-winded. Most people don't believe that. So I want to make sure that I thank all the members who are here. And so I promise that we're thanking Ben Ray Lujan and Joaquin Castro and terrible feedback. I'm going to go up there real quick. And Joaquin Castro. I mean, we've had a really dynamic group. group of members of Congress throughout the day and a half. So I'm very proud of that effort, and I'm very proud of the University of New Mexico and the Robert Wood Johnson Foundation. Second thing, we thought we had enough time not only to have Congresswoman Roy Ball-Aller talk about the Health Equity and Accountability Act and next steps, but to wrap up this conference. And I feel terrible because three women in this audience spent a great deal of time last night recapping, and we aren't going to do that. That'll teach you to stay up past 2 a.m. and do my work for me. But I want to tell you this, that it is clear, based on this conference, that the barriers that exist in access, many of which we've known all along, but in the context of policies that will do something about them in short order, I assure you that many members of Congress, including myself, are going to introduce legislation that remove those barriers and focus on health care for women and their families. And let me do this, all women and their families. This is a time to be courageous, not a time to be shy and unassuming. And your effort today, your efforts yesterday, your efforts in the work that you do every day make a difference to the policymakers in Congress. And I just wanted to let you know, and the one takeaway for me is that I'm learning public health. I didn't come at it like everybody else here. And I would have worked diligently to keep on the disparity track until we close those gaps. It didn't occur to me until this conference that what we ought to be doing is just working on health justice in the same way that we work on equity across all issues. And if we talk about and work on health justice, we can be the #1 healthcare outcome for all populations in this country, for the entire world. And that has to be our goal, and that's going to be our work. And thank you very much for doing it.
I'd just like to say a few closing remarks too on behalf. I'm really thankful for this opportunity to be here and listen to all of you. You know, we have all these disparities, but yet we need justice, and yet we need our congressional people here to listen to us. I think we're all here to educate ourselves. What our worker ants are doing out there in the fields, what kind of resources that we have here within our states. You know, this is not only a one state effort, but I think it has to be a nationwide effort that we have to do. And it's going to be a never-ending process, a battle that we have to do every day. You know, to overcome what our communities are going through, especially our people, all of our people, young and old, middle. It's very important that we keep them healthy, mind, spirit, and body. My prayer is going to be, in closing, again, we're going to be asking our Creator thanks and His helping spirits to guide each and every one of you here. I think what I said before is we put our minds together as one, learn all we can from each other. I think we can overcome a lot of these obstacles. One thing is still be barriers. When I was growing up, our elders told me, you can go through barriers no matter what they are. You can go through them, over them, on the side, under them, or through them. So there's no barriers there. Something that each and every one of us can do. Like I told you, I'm responsible for my community members, each and every one of us. So leadership is important too, to have, to guide, because a lot of, in Pueblo country, a lot of tribal communities, our people look to their leadership for guidance, advice. And I'm sure there's some of your community leaders do that too. I hope they do. And work with them. Because this is what it takes for everybody to be here. Leadership, people like you to do all this work that's necessary. Congressional delegations that come over here. I welcome each and every one of you to our Pueblo in Santa Clara. Whenever you're out there, give us a call at the governor's office. Stop by, say hi. If it's lunchtime, I'll take you out to lunch. But in closing, thank you. And I'm going to wish each and every you a safe journey and to have your families be safe with all the work that you're doing. I know sometimes we have to take time off at odd hours or all the time, and we're not there with our families most of the time, which we should be, but I'm going to be praying for all of you to have the strength, the guidance, the wisdom to talk. And these words that I'm doing in our language aren't my words. These are words that were handed by my ancestors through generations. This is what we pass on to our children, to learn these words, to follow them. To, what do you say? Practice what you preach. That's what they are. So, in closing, thank you, everyone.
What's in
queda sata to chiro kagi on no about the kuda por one about the no we to make it like the no we to